Good afternoon, dear students. Today we continue lectures about tuberculosis. Topic of today's lecture: detection of tuberculosis, classification of tuberculosis, and primary forms of tuberculosis. First part of our lecture, detection of tuberculosis. The main source of Mycobacterium of tuberculosis are people who suffer from the open form of tuberculosis and who discharge bacteria. The main objective of TB program is to block the paths of TB process. A person discharging bacteria can infect many people, and these people can ill with tuberculosis later. Therefore, the goal of the TB program is to prevent infection of people. We should stop this process. The main source of the infection are the people who suffer from the open form of TB. They have to be identified and isolated to prevent the infection of children. The first phase of this program is the organization of early detection of TB patients. There are two variants of detection of TB patients. First variant, active detection. This is X-ray examination once in a year. And second variant of detection is passive. In this variant, we using patients' complaints. For active detection are used fluorography, digital or mobile fluorograph. Active detection do X-ray of the chest once in a year. X-ray examination is used for people who aged 14. X-ray examination is preferably carried out at fluorography devices and X-ray machines with digital image processing. On this photo, you can see digital fluorogram. There are risk groups that require X-ray examination. First group, social risk. Second group, medical risk. Risk groups that require X-ray examination, social risk group. This is persons without a certain residence, persons who are registered with the device, migrants, refugees, individuals who are looking for work and unemployed, members of low-income families and people on the registers of the Departments of Work and Social Protection. Medical risk groups. This is patients with diabetes mellitus, patients using glucocorticoids, cytostatics, patients with chronic lung diseases, HIV-infected persons, persons who are registered in tubes, drug and psychic clinics, and persons who contact with ill with TB people. For example, family, occupational, nosocomial, and prison. On this film, you can see the active detection scheme. If at examination we not found changes on X-ray, thoracic cavity organs without pathology, X-ray picture or record is kept in X-ray archive. If in TCO are revealed pathological changes in lung or interthoracic lymph nodes, in the forms of foci, induration, or calcifications, patient's X-ray archive is analyzed. If in TCO are revealed destruction, cavities, dissemination, or increased intrathoracic lymph nodes, it must be consultation of a physiatrician and differential diagnosis with other lung diseases and further diagnosis of tuberculosis. If in thoracic cavity organs are revealed pathological changes in the form of infiltration, must be the study of sputum using microscopy. And more detail about these methods. If pathological changes in the lungs or in the intrathoracic lymph nodes are revealed in the form of foci, induration, or calcification, patient's X-ray archive is analyzed. On this photo, you can see, on this X-ray, you can see focal shadows in the right lung. In this case, we should analyze archive, X-ray archive. If in the organs of the chest destruction cavities are revealed, it must be consultation of physiatrician and differential diagnosis with other diseases of the lungs and further diagnosis of tuberculosis. On X-ray and on a picture, you can see a cavity in the right lung. If in the organs of the chest pleural dissemination or increased intrathoracic lymph nodes are revealed, it must be consultation of physiatrician also, and must be differential diagnosis with other diseases of the lungs and further diagnosis of tuberculosis. On the left X-ray, you can see lymph nodes, increased lymph nodes. in the left side. And on the right X-ray, you can see dissemination. That's why many focal shadows in both lungs. In these cases, must be consultation of a pediatrician. If in the organs of the chest pathological changes in the form of infiltration are revealed, we should do examination of sputum using microscopy. And on this X-ray, you can see infiltrative shadow, decrease of pneumonization in the right lung. And this shadow looks like on non-specific inflammatory disease. Therefore, first of all, we should use examination of sputum. Disadvantages of fluorography. It isn't an objective method, and its quality depends on the skill of the radiologist. It cannot be used for all social risk groups. It does not detect tuberculosis in time, because tuberculosis can develop in 2-3 weeks. Especially in the patients with co-infection HIV plus tuberculosis. It cannot reveal the etiology of the disease. We can see only shadow on X-ray. And this shadow we should differentiate it. It requires expensive equipment, consumables, and skilled workers. It has low detection of people who discharge bacteria, only 1.1 up to from 0.1 up to 0.01% identify. Next variant of detection, passive detection, is passive detection. Patients with tuberculosis have complaints and pathognomonic complaints for tuberculosis. First of all, cough more than 2 weeks, long time coughing, more than 2 weeks. Next, febrile or low-grade temperature, is typical for patients with tuberculosis. The loss of body weight as a result of loss of appetite. Night sweat, pain in the chest, and sometimes hemoptysis. The most pathognomonic complaint, cough more than 2 weeks. In these cases, we should take 2 portions of sputum. First portion is taken at first appearance, second portion the next day, 2 times. Patient pass sputum analysis. At passive detection, we use radiography or fluorography of the chest also. And if we found pathological changes in the chest, used the sputum analysis for revealing of Mycobacterium of tuberculosis. If patient has complaints but pathological changes not found, there is no need for additional examinations. And after examination of sputum for revealing of Mycobacterium of tuberculosis, if Mycobacterium is positive, found Mycobacteriums, patient must be isolated and hospitalization in TB clinic. This is very dangerous patient if we found Mycobacteriums in sputum in microscopy. If after the sputum examination, if Mycobacterium are not found and Mycobacterium is negative, we should treat this patient as community-acquired pneumonia of moderate severity. It is strictly forbidden to use rifampicin, aminoglycosides, and fluoroquinolones. And after 2 weeks, we should do X-ray control. For this case, for treatment used antibiotics of wide spectrum of action, except rifampicin, aminoglycosides, and fluoroquinolones, I repeat. If at control X-ray examination after 2 weeks positive clinical and radiographic dynamics, we continue to treat non-specific pneumonia. If after treatment the lack of positive dynamics need additional tests, a CT scan and bronchoscopy, and consultation of TB specialist for differential diagnosis with other diseases of the lungs and further diagnosis of tuberculosis. The advantages of the method of sputum microscopy. Easy to use, immediately reveals the etiology disease and allows to start effective etiologic therapy. It allows you quickly hospitalize people who discharge bacteria in TB clinic, interrupting the infectious chain of transmission from one individual to another. It does not require further study. Reduced the risk of infection of staff and patients. It don't require expensive equipment, supplies, and trained medical personnel. High degree of detection of Mycobacterium tuberculosis, up 5%. It does not use the radiation that can hurt the patients. Disadvantages of the method of sputum microscopy. The need for selection of patients for the study of sputum. Cough must be productive and the sputum must be present. Sputum picking should take place only under medical supervision. The conditions of storage and delivery of sputum to the laboratory must be strictly followed. Laboratory equipment must fully match the standards. And one smear must be researched for about 20 minutes, very long time, while reviewing 300 fields of view. It's very difficult for medical personnel. Here you can see smears of TB patients according Zil-Nielsen, staining according Zil-Nielsen, method of Zil-Nielsen. For a consultation to the specialist, you should immediately send the following patients. First, for suspected extrapulmonary forms of tuberculosis, including children. Second, if it is impossible for a doctor to use any of the diagnostic methods. Solutions to the problem of detection of tuberculosis. The active visits to the potential discharging bacteria people, families of people suffering from alcoholism, risk group also, people who use drugs, risk group also, accommodation of homeless people, and places with street beggars. The mechanism of detection of Mycobacterium of tuberculosis infection. Mycobacterium of tuberculosis gets to the human blood through the air. Airborne way is the most often. The blood spreads throughout the body, synthesizing it, tuberculoprotein, and the introduction of tuberculin, a specific protein, causes an allergic reaction. Tuberculin diagnostic test that is used to identify a specific tuberculin allergies caused by TB infection or BCG vaccination. Intradermal tuberculin Mantoux test with 2 tuberculin units of purified tuberculin in standard dilution is used. This is specific allergen. The result of the Mantoux test is evaluated after 72 hours by measuring the infiltration in millimeters with a ruler. We usually use transparency ruler. And on this photo you can see papilla of 15 millimeters. It means reaction is positive. Evaluation of the results of the Mantoux test. There are 4 reactions on this test. First result is negative. Negative is the total lack of infiltration. Erythema reactions from 0 to 1 millimeters. Next reaction, doubtful. This is infiltrate or papilla sizes from 2 to 4 millimeters, or only hyperemia of any sizes without papilla. This reaction named doubtful also. Third reaction, positive. This is infiltrate or papilla with a diameter of 5 millimeters or more than 5. And last reaction named hyperergic. This is infiltrate a diameter of 17 millimeters or more in children and 21 millimeters or more in adults, as well as vesicular necrotic reaction regardless of the size of the infiltrate with lymphangitis or without him. And on this photo you can see vesicular necrotic reaction of large sizes more than 21 millimeters. This reaction named hyperergic reaction because form vesicular and necrosis. Next method for detection of tuberculosis named Diaskin test. Diaskin test is drug that is used for the diagnosis of tuberculosis. The product contains 2 antigens present in virulent strains of Mycobacterium tuberculosis and absent in the vaccine strain of BCG. There is no reaction to Diaskin test for individuals who are not infected with Mycobacterium of tuberculosis, individuals who were previously infected Mycobacterium of tuberculosis with inactive tuberculosis infection, latent infection, for example, and individuals who recovered from tuberculosis. The main objective of physiology is to block parts of tuberculosis infection in infection process. If we are unable to prevent human infection and to provide care to affected children, it is necessary to treat TB patients. Next part of our lecture, today's lecture, classification of tuberculosis, clinical classification of tuberculosis. Clinical classification of tuberculosis contain several parts. First, clinical and radiological forms of tuberculosis. Next part, characteristics of tuberculosis, localization and prevalence. Next part, the course of the disease or phases of process. Next part, the presence of smear. And next, complications of tuberculosis and residual effects are cured of TB. And more detail about these parts. First part, clinical forms of tuberculosis. There are many forms of tuberculosis, but the most often can affect lung tissue. Therefore, all forms are divided on pulmonary forms and extrapulmonary forms of tuberculosis. Here you can see all forms of pulmonary and extrapulmonary tuberculosis. TB intoxication of children and adolescents, tuberculosis of the respiratory system contain many forms of TB. This is tuberculosis primary complex, tuberculosis of intrathoracic lymph nodes, disseminated pulmonary TB, miliary tuberculosis, focal pulmonary TB, infiltrative tuberculosis, caseous pneumonia, the lung tuberculoma, cavernous pulmonary tuberculosis, fibrous cavernous pulmonary TB, cirrhotic pulmonary tuberculosis, tuberculosis pleurisy, including empyema, tuberculosis of the bronchi, trachea, upper respiratory ways, and tuberculosis of the respiratory system combined with occupational dust diseases of the lungs, or other name coniotuberculosis, pneumoconiosis plus tuberculosis. All forms of tuberculosis we can divide it on primary tuberculosis and secondary tuberculosis. There are only 3 forms of primary TB. This is TB intoxication of children and adolescents, tuberculosis primary complex, and third form, tuberculosis of intrathoracic lymph nodes. All other forms of TB are secondary. Next part of classification, characteristics of tuberculosis include localization and prevalence. Process can localize in the lung or in other lungs or in other organs. Can affect lung or both lungs, lobes or one segment or polysegment, multiple segments. Next characteristics of tuberculosis. Phase of process. All phases we can divide it on 2 variants. First, phases of progression of process, and second, phases of regression. Phases of progression. A. Infiltration, decay, contamination. And phases of B phases, resorption, induration, scarring, and calcification. This is phases of regression of process, or phases of outcome of disease. And on this photo, you can see phase of dissemination. Many focal shadows, lesion in the lung. Next characteristic of tuberculosis: bacteria location. If we found bacteria of tuberculosis in sputum or in other fluids of organism, it means this person is bacteria excretor, MTB positive. If without isolation of Mycobacterium tuberculosis in sputum analysis, Mycobacterium is negative. This patient is not dangerous for us, for healthy people. And on this photo, you can see a method of revealing of Mycobacteriums. Sputum microscopy with staining by Ziel-Nielsen. Mycobacteriums of red color on blue background. This is rods or bacillus. Next characteristic of tuberculosis: complications. There are many complications, and all complications we can divide it on two groups: specific and non-specific. On this picture, you can see all non-specific complications of tuberculosis: hemoptysis and pulmonary hemorrhage, spontaneous pneumothorax, pulmonary heart diseases, atelectasis, etc. All these complications are not specific for TB. These complications can be formed in other diseases also. For example, at cancer, at bronchiectasis, etc. Specific complications for tuberculosis all complications which name tuberculosis or tuberculosis. For example, tuberculous meningitis, tuberculous pleuritis, etc. If the main process is localized in the lungs. Next characteristic of TB: residual changes after tuberculosis. For respiratory system, the possible formation of fibrosis, dystrophic bullosa, emphysema, calcifications in the lungs and lymph nodes, cirrhosis, etc. Other bodies: psychiatrical changes in organs and their consequences. And on this photo, you can see X-ray of the chest with many calcifications in the lungs, many focal shadows with calcification. This is post-tuberculose changes. Next part of our lecture: primary tuberculosis. Primary tuberculosis is the main form of the disease in childhood. It is diagnosed in 10–20% of cases among adolescents and young adults. Pathogenesis of primary tuberculosis. Infection occurs by airborne. Mycobacterium of tuberculosis deposits on the mucosa of the tonsils and dies under the influence of factors of local immunity. If this barrier is overcome, Mycobacterium of tuberculosis lymph current fall in the cervical lymph nodes, causing lymphadenitis. Dying Mycobacterium tuberculosis leaves fibrosis in the lymph node. Mycobacterium of tuberculosis overcomes the barrier of the cervical lymph nodes, captured by the macrophages into the lymph nodes, where causes inflammatory reactions in the form of epithelialization tubercles. On this photo you can see the macrophage and Mycobacterium tuberculosis. Affects the intrathoracic lymph nodes. Specific inflammation spreads to the surrounding tissue on the wall adjacent to the node of the bronchi and enters the bloodstream. This is bacteremia. On this X-ray, you can see hyperplasia of the intrathoracic lymph nodes of the right root of the lung, increase of lung root. This is affection of intrathoracic lymph nodes. Organism is sensitized, acquiring hypersensitivity of the delayed type. It can be defined by a positive tuberculin skin test, a Mantoux test, and Diaskin test. On this photo you can see result of Diaskin test, hyperemia with papilla. This is positive reaction. According to clinical classification, there are 3 clinical forms of primary tuberculosis. First, tuberculous intoxication. Second, tuberculosis of intrathoracic lymph nodes. And third, primary tuberculosis complex. And more detail about each form. Tuberculosis intoxication of children and teenagers. Diagnostics is based on positive and increasing dynamics of the tuberculin skin test. Intoxication syndrome without local X-ray manifestations of the disease. That's why in this form of TB, for this form of TB, intoxication is characterly symptoms of intoxication, local changes are absent. We cannot find any changes on X-ray. Only intoxication syndrome is present. It is accompanied by deterioration of the general condition of a child or teenager, low-grade fever, neurovegetative disorders with tendency to intercurrent diseases. Micropolyadenitis may be determined during examination of a child. Slight enlargement of the liver, less often the spleen, and weight deficit. Patients with tuberculous intoxication have ESR acceleration, shift of the neutrophils to the left, eosinophilia, lymphopenia in peripheral blood. Immune status is altered, reducing number of T lymphocytes and their functional activity. Specificity of symptoms should be confirmed by examination of a child or teenager for excluding non-specific diseases. Computer tomography, bronchoscopy, tuberculin diagnostics, and bacteriological tests, obligatory methods of examination. Diagnosis can be made only after the examination in tubercular institutions. Tuberculous intoxication often ends with recovery. The inflammation decreases and granulation transforms into connective tissue. Caseous lesion, calcium salts are deposited. Also, in this disease can appear ill forms of Mycobacteriums of tuberculosis. This is not typical Mycobacteriums of tuberculosis. This is not virulent Mycobacteriums. The person remains infected for whole life. Persistent infection can be a source of reactivation of tuberculosis and to cause the maintenance of TB immunity. The infection spreads mainly through the lymphatic system with the progression of primary tuberculosis. First of all, infection strikes intrathoracic lymph nodes. On this preparation, you can see intrathoracic lymph nodes affected. Lymph nodes. And next form of primary tuberculosis, tuberculosis of intrathoracic lymph nodes. This form of tuberculosis occurs as a result of primary TB infection of children, adolescents, and adults from 18 to 25 years, young people. The scheme of arrangement according Sekenikov. All groups, there are 4 groups of intrathoracic lymph nodes. First group, paratracheal, located along trachea. Second, tracheobronchial localization in place of between trachea and the main bronchus. Bifurcation lymph nodes. And fourth group, bronchopulmonary lymph nodes, located along bronchus in the lung tissue. And clinic depend on affection of different groups of lymph nodes. Classification of tuberculosis of intrathoracic lymph nodes. There are 3 clinical rentgenological forms of this form. First form named tumor-like, second infiltrative, and third small form of bronchoadenitis. And on this photo you can see hyperplastic lymph node. Infiltrative form of tuberculosis of intrathoracic lymph nodes. This form is characterized by the development of infiltrative changes in roots of the lung. Formation of perifocal infiltration of lymph nodes are typical for this form. That's why specific inflammation spread from lymph node to lung tissue around of this lymph node. And the main clinical symptoms is intoxication syndrome. Intoxication syndrome prevail in this form of tuberculosis. On X-ray, in this form of TB, in infiltrative form of tuberculosis of intrathoracic lymph nodes, we can see decrease of lung root without clear borders. This is perifocal infiltration of lymph nodes. Process spread from lymph node to lung tissue around it. On this X-ray, you can see perifocal infiltration of lymph nodes also in the left lung root. Increasing of lung root without clear contour. Here you can see perifocal infiltration of lymph nodes also. And on X-ray in lateral position, we can see infiltration of the root of the lung without clear contours also. Next form of tuberculosis of intrathoracic lymph nodes, named small form. This form characterized by a slight enlargement of the lymph nodes. And the clinic, mild symptoms of intoxication or without them. Possible dry cough, small inflammatory changes in the blood, peripheral blood, and positive tuberculin skin test. Lymph nodes are very, very small in this form. X-ray diagnostics of small forms of TB of intratracheal lymph nodes in the initial phase is possible only by indirect sign. Decrease patterns of the shadow, the root of the lung. The enrichment of lung pattern in the root zone. Better to use for revealing of small form of bronchoadenitis tomography or CT scan. Because in this examination, enlarged lymph nodes we can see better than on X-ray. On this X-ray, you can see this is tomography of the lungs, and we can see enlarged paratracheal lymph nodes. This is linear tomography, and we can see only one layer of the lung through lung roots. On this tomography, we can see sealed bronchopulmonary lymph nodes. Lymph nodes are very, very dense. This is tomography through lung roots also. In a later period, 3-6 months after the onset of the disease, lymph nodes are compressed and calcified. Compacted and calcified, sorry. X-ray becomes more reliable. On this photo, on this X-ray, you can see bilateral calcification of the lymph nodes. Very dense lymph nodes in both sides. In this period, lymph nodes visible better than in first period. On this X-ray, we can see small dense lymph nodes also along bronchus. This is a group of heavily calcified bronchopulmonary lymph nodes. Localized in the lung tissue along small bronchus. Next form of tuberculosis of intrathoracic lymph nodes, named tumorosis form or tumor-like form of TB of intrathoracic lymph nodes, characterized by enlarged lymph nodes without perifocal reaction. That's why process is not spread on lung tissue around of lymph node. The clinic, moderate intoxication syndrome or without it. Pulmonary syndrome due to irritation of the bronchial mucosa, inflamed lymph nodes. On this X-ray, you can see enlargement lymph nodes in the right side with clear borders, without inflammation around them. That's why contours are clear. This tomography We can see tumorosis lymph nodes also in the left lung root. Here on this tomography we can see tumorosis lymph nodes also, and lymph node is not homogeneous with dots with islands of petrification. Differential diagnosis of the tuberculosis of intrathoracic lymph nodes do with different diseases. First, lymphogranulomatosis. On this preparation, you can see enlarged lymph nodes of the lung root also. But for tuberculosis, caseous necrosis is characterly. Here, caseous necrosis is absent. On X-ray, we can see enlargement lymph nodes also. Looks like on tuberculosis of intrathoracic lymph nodes on X-ray only on X-ray. On this CT scan, we can see lymphogranulomatosis with lesions of the lung. Next disease for differential diagnosis, lymphoma. On this X-ray we can see enlargement of mediastinum. Looks like on tuberculosis of lymph nodes on X-ray. This is CT scan, lymphoma also. Enlargement of lymph nodes. Next, disease for differential diagnosis, sarcoidosis, first degree of this process. We can see hyperplastic lymph nodes in both sides. This is more typical for sarcoidosis because for in tuberculosis can affect lymph nodes of one side more often. Sarcoidosis, both sides are affected, and this symptom name symptom of butterfly. Looks like on butterfly, affection of lymph nodes in both sides. And you can see clear contours of lymph nodes also. Sarcoidosis first degree. And here we can see hyperplastic lymph nodes also in both sides. Decrease of lung roots on both sides of the lung, of the chest. And enlargement lymph nodes at sarcoidosis in first degree. On CT scan, we can see hyperplastic lymph nodes also on both sides. And for differential diagnosis of tuberculosis of intrathoracic lymph nodes and other diseases, use complex examination. It must be CT scan with contrast in with contrast CT scan, scintigraphy we can use also, laparoscopy with biopsy of the lymph nodes, bronchoscopy with biopsy of mediastinal lymph nodes, mediastinoscopy, and thoracotomy. On this photo you can see thoracoscopy, video thoracoscopy with biopsy of lymph node. Next form of primary tuberculosis, name primary tuberculosis complex. If Mycobacterium of tuberculosis fall into the alveoli, they cause a local inflammatory response in the specific form of pneumonia in lung tissue, pneumonic phase. And on this photo, you can see on this scheme, you can see pneumonic phase of primary TB complex, pulmonary component. Looks like on pneumonia. Therefore, name pneumonic phase. Then, Mycobacterium of tuberculosis get the lymphatic nodes of mediastinum, causing inflammation. Primary tuberculosis complex is forming there. And on these photos, you can see different phases of primary TB complex. First picture, phase of bipolarity. We can see all three components of complex. Pulmonary complex, lung, pulmonary inflammation, lymphangitis, and inflammation in lung root. That's why affected lymphatic nodes of lung root. And on second picture, you can see last phase of primary TB complex, named phase of calcination or calcification. Primary tuberculosis complex has three stages. First stage, named pneumonic stage. Second stage, bipolarity. And third stage, named calcination. And on this preparation, you can see lung with pulmonary lesion and affection of lymph nodes, glandular lesion. This is macro preparation after operation. Clinic of primary TB complex depend on phases of process. In beginning of disease, when form pneumonic, form inflammation in the lung and inflammation in the lymph nodes, intrathoracic lymph nodes. That's why in the pneumonic phase, intoxication and pulmonary syndrome prevail. And the clinic depends on the size of pneumonic focus. If pneumonic focus is large, it will be more severe clinic. If affection is small, a clinic can absent. And on this macro preparation, you can see pneumonic infiltration also. This is large volume of affection, therefore, in this case, all clinical symptoms are severe. And on X-ray we can see pneumonic infiltration. That's why this stage of primary TB complex on X-ray looks like on pneumonia. Therefore, name pneumonic infiltration stage. And in this stage, first stage, we should differentiate primary TB complex and pneumonia. First of all, we should treat pneumonia. If effect of treatment is absent, we should treat tuberculosis. Here on this X-ray you can see a pneumonic infiltration also, and this is first phase of primary TB complex, pneumonic phase, pneumonic stage. In this stage usually we cannot see all three components because these components fuse together, and we can see only pneumonic infiltration. This is pneumonic infiltration on CT scan, connected with lung root also. Next phase, second phase of primary TB complex, named phase of bipolarity or phase of resorption. Intoxication syndrome is reduced due to the resorption of the pulmonary component. Pulmonary syndrome increases with the increase of the glandular component. That's why lymph nodes of the root. If lymph nodes enlargement, they can compress bronchus. Therefore, pulmonary syndrome can present. And here you can see all three components of primary TB complex. First, glandular component, second, lymphangitis, and third, pulmonary component, infection of lung tissue, specific inflammation in the lung tissue. On these X-rays, you can see phase of bipolarity also. All three components we can see. Pulmonary component, lymphangitis and lymphadenitis in the root of lung. Infection of lung root. Here also can see phase of bipolarity. All components are visible. Infiltration in the lung tissue, lymphangitis, and enlargement of lung root. Affection of lung root, affection of lung root, affection of lymph nodes in the lung root, and affection of lung tissue. Can see also. This is phase of bipolarity on CT scan. In this layer we can see all three components. And the third stage, named phase of calcification or calcination, clinically characterized by the absence of symptoms, because it is limited process. And on the macro preparation you can see calcification in the lung. And calcification of lymph nodes in the lung root. Caseous necrosis in the lung and caseous necrosis in the lymph node of the root. And on X-ray, we can see in this stage single or plural focal shadows. On this X-ray, we can see a single focal shadow with calcification in the upper lobe of the left lung. These focal shadows is not homogeneous. We can see islands of petrification. This is last stage of primary TB complex. And this focal shadow name Ghon's focus. Or post-primary changes. On this X-ray, we can see multiple calcification. That's why many focal shadows in the lungs and calcification in the lung root, in the right side, in the upper lobe of the right lung. This is post-primary changes also. Formation of the ossification Ghon's focus is characterized by a symptomatic course, because this is very small process, local process. And on this photo, on X-ray, we can see single focal shadow at the lower part of the left lung. And on macro preparation, you can see single focal shadow with caseous necrosis inside, necrosis of white color. Complications of all primary forms of tuberculosis can form different complications. For example, chronically recurrent primary tuberculosis, atelectasis of the lobe of the lung as a result of compression, fistula between the bronchus and the lymph node. Pleurisy can be a complication of TB, primary TB. Miliary tuberculosis can form as a result of hematogenous dissemination. Primary caseous pneumonia. Primary cavity can form, primary cavina. And primary tuberculoma can form also. This is chronically recurrent primary tuberculosis. We can see decay inside of focal shadow in lower part of the left lung. It means process is progressed. And we can see dense lymph nodes in the left lung root. On this X-ray, we can see miliary tuberculosis as a result of hematogenous dissemination of primary form of TB. Mycobacteriums can spread by blood from lymph node as a result of decay of lymph node, and by blood can spread in different parts of the lung. And on X-ray, we can see many small focal shadows. This is total dissemination. Pleuritis can form as a result of primary TB, can affect the pleura. On this X-ray, we can see exudative pleuritis of both sides, affection of both sides, the pleural fluid in both sides, more in the left side, less in the right side. Primary caseous pneumonia can form also complicated primary TB. This is affection of one lobe of the lung and more than one lobe with many cavities of destruction. And on this X-ray we can see decrease of pneumonization of upper lobe of the right lung with clear contour along horizontal fissure, with many cavities of destruction and with dissemination in both lungs, to right lung and to the left lung. Atelectasis of the lobe of the lung can form also as a result of compression of bronchus, especially in small babies. Enlargement lymph nodes, dense lymph nodes can compress bronchus, or viscous mucus can be a cause of atelectasis also. Viscous secret of bronchus. Can form primary cavities also. You can see on this X-ray in the right side phase of bipolarity of primary TB complex and lung component with lightening inside. This is decay. This is formation of cavity as a result of destruction of lung tissue. That's all. Thank you for your attention. See you next time. See you next lecture.